Testosterone replacement therapy side effects. Well, with a optimized TRT protocol, you shouldn't have side effects. However, it isn't uncommon to have side effects. Now, why is that? Now, irrespective of the other external factors that may cause side effects, can you mimic the natural physiology of testosterone within the body with TRT? Now, the answer to that is unfortunately no. Why is that? Well, within the body, there is normal diurnal variation of testosterone levels, something that cannot be replicated with testosterone replacement therapy. So, obviously, your anabolic processes predominate at nighttime, and so testosterone is produced then, hence your early morning levels are highest, hence measuring them in the early morning. We do try and achieve stability. That's the purpose of testosterone replacement therapy, achieving stability. So we are hoping that we will have a constant level throughout the day, throughout the night. Now, even with a optimized TRT protocol, you will have minor peaks and troughs, because obviously when you inject, you will have a slight peak. So it's impossible to avoid that. Does it matter on an optimized protocol? No. HCG, again, physiologically, luteinizing hormone is released in a pulsatile manner. So when we add HCG into your protocol, which is integral to an optimized TRT protocol, then you have a constant flow of HCG, which mimics LH to the testicles, which produces intratesticular testosterone and subsequent aromatization of the testosterone to estrogen. Obviously, the other benefits of HCG is the upregulation of other hormones down from pregnenolone to cortisol, aldosterone, and testosterone, and also the electroreceptors in the brain, hence the increase in libido. So, even with an optimized TRT protocol, you are not perfectly mimicking the natural physiology. Does it matter? No, not normally. However, just be conscious of that. So, side effects. Side effects tend to occur when you're not balanced, when your TRT protocol is not optimized. They tend to occur obviously on initiation, on commencing treatment, and they tend to occur when your protocol frequency of injections is wrong and your dosage is wrong. Now, I'm not going to bore you all with the sustanon discussion because we've done that ad nauseum. So, as you know, we don't use that. So, with the single esters, normally you can decrease side effects and hopefully eliminate side effects with simple dose alteration and or alteration of your frequency of injections. So normally it's a problem with the protocol. Now, if you do have side effects, then what are the common side effects? Well, common estrogenic side effects include breast tissue swelling, nipple tenderness, water retention, and symptoms of anxiety and loss of libido. Now, that's unfortunately due to our body's propensity to aromatization. Now, obvious things that you can do to minimize aromatization include optimizing your liver health. Now, obviously the liver detoxifies everything in the blood, so you need to stop stressing the liver. So eat clean, take as minimal chemicals as possible, because we are animals. Remember, animals. So exposing yourself to artificial chemicals is typically bad. Obviously not always bad. Some chemicals are necessary, but we should adopt the less is more approach and natural versus artificial. Alcohol, major irritant, and also body habitus. So if you're a big chunky monkey, then you want to decrease your body weight to decrease your subsequent aromatization. So they're common estrogenic side effects. Common symptoms of excess free T. Now you can have an abnormal lipid profile, so your HDL can go down if you're running too high. You can have an increase in your hematocrit, which is the concentration of red blood cells in the blood. Now, depending on who you listen to, that is either an issue or not an issue. Well, it is an issue. You know, some bozos try and make a clear distinction between polycythemia and erythrocytosis. There is not a clear differential between those two conditions. So if you have a higher concentration of red blood cells within the blood, so essentially you're making the blood more viscous, you are making the heart pump harder to pump the oxygen to the tissues in order to supply them. So you are putting more strain on the heart, and you are obviously, from an increased viscosity perspective, having more chance of blockages. So yeah, again, be careful who you listen to. I like my guys typically less than 0.5 because they do feel a qualitative improvement when they reduce their hematocrit. Sometimes it's unavoidable to have a raised hematocrit. It is typically, or normally within the first 12 months whilst you're getting stabilized. You know, you have to think about it from the perspective that, say you move to an area of high altitude and your hematocrit subsequently has to rise to pump that oxygen to the tissues because of the atmospheric pressure to change, your body can adapt. It has physiological mechanisms that make sure that your hematocrit doesn't rise too much, and compensatory mechanisms. Now, your body does not know you're about to inject testosterone. So especially for the first few months, you can get that rise in hematocrit because every time you inject, the body goes, change, change, change. It has to change. It doesn't know you're about to inject. So it's only until you get stable levels that your body can have those compensatory mechanisms to prevent you from having an elevated HCT. So it isn't uncommon that guys have to donate within the first 12 months. So it isn't uncommon. You know, it's quite rare actually now that we subscribe to the microdosing methodology, where we don't actually implement these massive peaks and troughs that you get with people on the infrequent injection frequencies of large amounts of testosterone that some other providers advocate. We are always trying to, as close as damn it, mimic our natural physiology. So microdosing is the sensible option for obvious reasons. We are trying to achieve stability, small frequent doses, not allowing the body to have a massive reaction from the peaks and troughs that more infrequent injections cause. As I'm sure I said this before in all of my other vlogs, we've got a lot of alpha guys who come in with sort of higher end free testosterones, and they go, "Doc, I'm a bit anxious, my erections aren't quite so strong, look at me, I need to have a bigger dose." We reduce their dose and they subsequently have an improvement in their sense of well-being, and their erections get stronger and they feel better. So whilst you might be a big dude, you don't need high numbers. You need numbers that are particular to your genetics, physiology and requirements. And that is why we carefully titrate your dose according to effect, and it makes sense. You know, chasing numbers. Oh. Right, free testosterone. So what else? DHT. Now, you rarely get symptoms of excess DHT. Now, if you have optimized free testosterone and estrogen, you tend to have a relative decrease in DHT. Now the reason for that is obviously testosterone gets produced by the testicles. So the concentration naturally is highest in the testicles. So the concentration of 5-alpha reductase that causes conversion of testosterone to DHT is highest around the prostate, hence the reason naturally you have a higher DHT compared to your counterpart who's on testosterone replacement therapy, who is injecting either intramuscularly or subcutaneously. So you very rarely get an excess of DHT. If you do get an excess of DHT, so symptoms such as prostatic symptoms, having to get up more frequently at night time, the urgency, frequency, all the dribbling, etc., hesitancy, and you lose your hair quick, or it tends to reflect a vastly over-aggressive TRT protocol. So normally your other numbers will be out of whack. So side effects on testosterone replacement therapy. It's not uncommon to have side effects whilst your optimal protocol is being titrated. So don't be disheartened if you do have side effects, but it should always be a work in progress. And as long as you're making positive steps and strides towards the optimized protocol, then you will be golden eventually. And as I said, most side effects can be managed by simple dose alteration and alteration of your injection frequency. As I said, sometimes we do use an aromatase inhibitor. We carefully titrate that dose so that you don't crash your estrogen. As you know, I don't use anastrozole, I use exemestane, and we microdose that. But it's always a work in progress. So it's always a work in progress from a perspective that what we're trying to do is get you feeling great with the minimum amount of chemicals possible. So gold standard testosterone replacement therapy is testosterone, a single ester, either testosterone enanthate and testosterone cypionate, and HCG, which mimics luteinizing hormone. If you need any adjuvants to that, then we do it sensibly. We do it under strict supervision so that we are always working in your best interests. Ta-da.